So the way that I've been doing my reviews is I usually open it up to whoever's here and ask like if there's anything specific they want clarified before the exam. If not, we can play like a couple of Kahoot review games, but since it's only you, if you want to have it be more like things that you really want to know, or have trouble with, then we can kind of go through those if you need.
Mhm. If we could go through maybe the medications
Okay.
and the max sulfates, clonus, no clonus, deep tendon reflexes, no deep tendon reflexes.
Yeah. Let's go through mag and the focused assessment with magnesium first. Let me pull up the PowerPoint that I have on that.
And if we could do some GTPAL,
Yeah.
um, uh-huh, when you have the stillborn, the live birth, and how do you count the stillborn as a life, as a birth nonetheless, a, a parity, or things like that.
Yeah, we can do all of that.
The stillborn, the twins. Mhm.
All right. So I have my PowerPoint pulled up. Let's go over magnesium first. Okay. So why are we giving magnesium in labor?
Magnesium to to protect the baby's brain and to slow down the contractions.
Yes, but why also are we giving it for mom? For mom's benefit. Why are we giving mag?
And so she doesn't go from pre-eclampsia to eclampsia.
Correct. Yeah. We're trying to prevent seizures. So with magnesium, it does work as sometimes it can be worked used to slow down contractions, right? Because it's going to relax the smooth muscles. And that ultimately could relax the smooth muscles of the uterus as well. What we're looking for as far as why we're giving it for moms that have hypertension is because we want to prevent any seizure activity. Magnesium is the number one thing that we give moms to prevent them from having seizures.
Mhm. Mhm.
um, and you're correct about the neuroprotection of the baby, but what type of, like, what infant are we going to be wanting to administer magnesium for? Like, if a mom's in labor, when would we be giving that for fetal neuroprotection?
Is it like be too broad to say the newborn, the fetus, I mean finding the right term, the fetus, maybe a baby that's in a little distress.
So, we're mostly going to be giving magnesium to babies for neuroprotection if the baby is early. If we're going to have a preterm baby or a preterm delivery, we're giving that magnesium in labor when they're preterm.
Yeah, that's right. That's what I was searching for.
You're good. Um, and the main one that we're protecting against with magnesium is cerebral palsy, is the number one.
They're protecting the baby from being born with cerebral palsy.
Yeah, so we're protecting their brain from developing any type of abnormal deficit. But the biggest one that we mention whenever we're talking about magnesium and prevention is cerebral palsy.
Mhm.
All right, let me go ahead and share my screen with you, and I'll go over the PowerPoint that I have with magnesium, okay? All right, so let me make this a little bit bigger here.
Oh, I might have to try it on if I can get it on my computer.
Here, let's see. Does this make it a little bit better?
Okay. Yeah, I
Okay,
won't be able to see. I'm trying to switch over as quick as I can.
no worries. Take your time.
Okay. So,
So, I'm gonna
on the
switch
phone.
from here from the phone.
Okay. Mm, um, I think I'm in. It's bigger. Let's see.
Is that a bit better?
Hmm. So,
Okay, so the biggest things that we want you guys to know whenever we're talking about magnesium, obviously, it is the number one choice or medication for preventing and treating seizure activity in a laboring mom.
Mhm.
Okay. Whenever for nursing indications and things that you want to know as their nurse, they're going to need two large bore IVs whenever we're starting this medication because magnesium is not compatible with a lot of other meds. So we need to have two accesses. Your initial loading dose is going to be 4 to 6 gram bolus. And the other thing you should know about that too is that you need to stay at the bedside with the patient whenever you're giving them that bolus dose.
For how long? I mean, stay at the bedside and then check them every.
Whenever I'm giving a mag bolus, I'm doing their vitals and I'm doing their focused assessment every 5 minutes.
Every
Because
5 minutes.
that bolus goes in over 15 to 20 minutes, right? So
Yes.
you need to assess for magnesium toxicity um, pretty frequently since it's such a short amount of time that that medication is going in.
Mhm.
So,
And you stay with them for the first 15, 30 minutes. You stay with them and then you check every 5 minutes.
mhm.
Mhm.
And it's a little bit different for hospital policy. So I want to get too caught up on like the vital parameters. What you should know for the exam are what are your signs and symptoms of magnesium toxicity? How do you know if your patient is getting too much magnesium and you need to slow the rate or stop it completely? What are some things that how would they present?
Okay, so with magnesium sulfate, you have to be careful because they can go into respiratory depression.
Yes.
Their deep tendon reflexes can go absent, which is not good. You would need like 1+, 2+, on the deep tendon reflexes. That'll be fine. And
Would
Mm,
confusion be one?
Yeah, they're gonna lose their level of consciousness. They will be
yeah,
like alert and oriented, and then
yeah,
all of a sudden they're gonna be like a little bit
yeah.
sleepier, not as responsive, you know. Let me see.
Okay.
Yeah, the LOC is gonna go down. Yeah, level of
So
consciousness.
we have that here. These absent deep tendon reflexes is a big one. That's why your focused assessment with magnesium should include a neuro check their if they're alert and oriented. You should be listening to their lung sounds because with magnesium and the way that preeclampsia works in the body, we're worried about what fluid or overload, right?
Yes.
I don't know where my PowerPoint just went. Oh, hold on. There. So you're listening to their lung sounds to make sure their lungs are still clear and that you're not hearing any fluid build up in their lungs. You're going to be doing those deep tendon reflexes. So using either the end of your stethoscope to like hit on their nerve points on their elbows and on their knees to see if they have the +1 or +2 reflexes. If their reflexes are absent, that is something you're going to want to notify the provider. That is something that we might want to stop the magnesium because of toxicity. But these three here that I have listed are the biggest ones: your absent DTRs, your decreased respiratory rate, and your decreased level of consciousness.
And what sounds would you hear in your lungs? What sounds should you hear when you listen to their lungs?
Uh, well, they should be clear.
Okay.
If you're hearing like crackles or you're hearing like any wheezing or anything, then that can be a sign of fluid volume overload and that they're developing some fluid in their lungs. So then we want to shut that mag off.
Can we just shut it off, or we have to get an order from the doctor?
You can shut it off. You need to have an order, and it is a two med verifier whenever you start the magnesium. But nursing judgment, you're allowed to shut it off.
Okay.
We would just have to notify the provider. And I've done labor and delivery for like 7 years now, and I've never had to shut mag off. Um,
Mm.
but if you do, most of the time you're probably calling close to a rapid response to get people to the bedside to help you.
Oh.
So that being said, your patient shows signs of mag toxicity. Okay, they have all the characteristics that we're talking about. We turned off our magnesium. What is our reversal agent?
Calcium gluconate.
Yeah, you got it. So that's something we want to have at the bedside, right? We don't want that to be in our Pyxis
Mhm.
all the way across the other side of the nursing unit. We are going to
Yeah.
have that at the bedside, and you want that at the bedside before you even initiate magnesium.
Mhm.
Okay. So all these other things that I have listed here, your assessment for your nursing action. So we mentioned that these patients with preeclampsia are at an increased risk for fluid volume overload, but because of the way that the blood vessels are constricted when they have preeclampsia, they are also at risk for urinary retention or renal insufficiency. So we need to make sure that these patients, because they are going to be getting fluid with this magnesium, that they are having an accurate urinary output, right? So whether that's a Foley catheter or a hat in the toilet, you need to be measuring their urine output. Patient,
Mhm.
so most of the time with magnesium, at least in the experiences that I've had, these patients are usually kept in bed. I've talked to some of the other professors who worked at bigger facilities, and the MAG patients aren't necessarily on bed rest. It just depends on your facility's policy.
Mhm.
Um, but these patients, so what are some things that they can experience with magnesium? Like, how would a patient feel that we're, these are things that we're not worried about them having mag toxicity. These can be normal side effects of the medication. What could we see?
Normal side effects of mine.
Yes.
Mm. Those are different from what we just have. The absent DTR.
Yeah, so this is different than mag toxicity. These are some things that your patient can experience that are normal, that aren't things that we need to be concerned about. Just like some stuff as like a nurse that you would want to know because you want to know the difference between what is a side effect and what is a toxicity level, right?
Like diarrhea,
Usually, if anything,
constipation.
everything's kind of slowed down, but they could have a little bit of some bowel movement, some incontinence. Yeah.
Mhm.
Um,
Dizziness,
what'd you say?
dizziness, like lightheadedness.
Yeah, so they can get like pretty lightheaded. What I tell my patients whenever I'm giving mag is I just tell them straight up, like, you guys are gonna feel like crap. This medication does not make you feel very good.
Oh,
They might
flushing.
have they might get really sweaty, they might be diaphoretic, they might
Mm,
just get really hot.
mm,
Nausea and vomiting is very common with magnesium, so I would administer an antiemetic.
okay. Yeah, I remember those. Mm. So separate the side effects from
Toxicity, yeah.
the toxicity.
So if your patient with MAG starts throwing up, that is not something that I would stop the medication for. It's an
Mhm.
unfortunate side effect, but it's not something that we're worried about, like central nervous system depression, right? Um, this is just unfortunately one of the things that the medication can do.
So you said being slowed down is it toxicity or is it side effects?
What was that?
You said like they get slowed down, is that toxicity or side effects?
That's usually a side effect, yeah. The biggest ones I want you to know for the exam for signs of mag toxicity are these three here: your decreased level of consciousness, your decreased respiratory rate, and your absent deep tendon reflexes. Those are the
Mhm.
biggest signs of mag toxicity.
Yes, I got it. For exam.
Okay, let's see if I have any. Did you want to go over the medications for blood pressure, or did you want to go over more medications that are going to slow down uterine contractions?
Um, I just we could go over the uterotonics and the tocolytics, but are we going to have to know all of them for the exam?
I'm not sure what exactly because we don't really get the access to the exam,
Yeah, I know, I know.
but I would just know the basis of
Each of them.
yeah, I would know the basic information for most of them. Let me see. I'll pull up my PowerPoint on that. So what are the major uterine tonic medications that we talked about or that you guys have learned about?
In Indocin, nifedipine, max sulfate, terbutaline. Do I need to know messaging?
No, that
And
one, yeah, no. The ones that
no,
yeah,
you
the
don't
ones
need.
you listed are good.
Okay.
What, like the oxytocin?
So oxytocin is a different type of medication, right? Because we're talking about meds that are going to slow and they're going to relax the uterus.
Yeah, the
So uterine
uterotonic.
relaxants or tocolytics.
Mm-hmm.
Oxytocin, methergin, and hemabate. Those three medications and Cytotec, those three
Okay.
medications are going to cause your uterus to contract, not
Mm.
relax.
Okay,
Okay.
so we leave that. Yeah, that's right.
So definitely know the difference between all of those medications and which class they fall into. Are they a tocolytic where they're relaxing the uterus, or are they going to contract the uterus for labor purposes or to prevent postpartum hemorrhages, which would be your Pitocin, your Methergin, and your Hemabate, and your Cytotec. Sorry, I keep forgetting that one. So with the tocolytics, the ones that we use the most on labor and delivery and that I would really know for the exam would be magnesium and your terbutaline. We just went over magnesium and kind of how that one is a tocolytic and how it is relaxing of the uterine smooth muscles.
Yeah.
Let me see. Let's talk a little bit about terbutaline. Okay, so terbutaline is a tocolytic. It is administered subcutaneously. The normal dose is 0.25.
0.25 milligrams.
I think it's micrograms. Wait,
Microgram.
milligrams. Yeah, it's given sub-Q 0.25 milligrams. And this medication acts by relaxing your smooth muscles by stimulating the beta 2 receptors. Some things to know about terbutaline. Moms can feel like their heart is racing if they get this medication. Like it makes their heart rate really elevated. They kind of feel like they're having an anxiety attack. Like they just feel like their heart is pounding and racing away from them. Sometimes with terbutaline administration, you can see an elevation in fetal heart rate if your baby is on the monitor, which they should be if you're giving this medication. So those are all things that we can expect to see with terbutaline that we aren't going to be concerned about. We just need to educate our patient on.
And we won't consider that as that's a side effect?
Yes.
Any diarrhea, any continence, any dizziness?
Let me pull up. Terbutaline usually doesn't have too many side effects.
Gets into that.
It's relatively safe to administer. Let me pull up the page in the textbook so that you guys know. All right, so the medications are outlined pretty much a lot more in detail in chapter 17. And I have the like physical hard copy of the textbook, so my pages are a little bit different than they are on the like virtual. But for a full like table of your adverse reactions and your nursing considerations, page 421 has a really great medication guide.
Okay. I'll look for it. The can cause tachycardia. And that is smooth muscles.
Yeah.
It's a bronchodilator.
Yeah, so go ahead and whenever you have time, that is a good table to review because it goes over like what normal adverse reactions are and then some nursing considerations whenever you're administering these medications.
It says like it may be contraindicated in women with heart disease.
Yeah, terbutaline.
Mhm.
Yeah, and the other things too, like, are you going to administer a tocolytic to a mom who comes in who's profusely bleeding?
No,
No, we're not going to, because
no.
we're worried about a rupture or an abruption or a placenta previa. You know, if that mom is progressing in her labor and needs to just have a C-section, we're not going to be administering a tocolytic because that can irritate the uterus more and cause more damage than good. So, and also like if we have a fetal demise or the baby doesn't look very good on the strip, like on the contraction monitor, we're not going to be giving these medications to slow down the contractions. We're most likely going to be evaluating the patient for an immediate C-section or delivery.
Mhm.
So it's just kind of using like that nursing judgment to be like, is this patient a candidate for these medications? Like, what else is going on with them? You know, we need to know the full picture and what we're looking at before we're just giving them these meds.
Mhm.
All right. What else do you guys want to review? You had mentioned GTP, GTPAL.
Yes.
Okay. So that stuff was on exam one. I think there should be, there probably is, it's not like it's not going to carry over into the other
It's
exams.
not gonna come
But
over. No.
what was the most confusing part about that for you?
The um the stillborns. The
Stillborn?
stillborns.
Okay.
Are
Was that on your
they are
exam?
a parity? They are gravidad. Um, how do we count them? A parity or gravidad. They won't be in the living. Um, and the twins, that's one gravida. And how many parity for twins?
Two.
One, two. Okay, so one gravida, two twins, two parities.
So you only have one, whenever you're thinking of gravida, that is just the pregnancy.
Yeah, so
With
it's one.
twins, it's only one pregnancy, right?
Mm-hmm.
But you're gonna have two living fetuses.
Mm-hmm. But no, but what about the parity? The delivery? How many deliveries is that? That's two.
That should be, let me look up my PowerPoint here. Hold
And the
on.
triplets, is that three? The quadruple, is it four?
Okay. So when we break each individual down, right, what does G stand for?
Gravida.
Yep, which is your total number of pregnancies,
Yes.
which that can include stillbirth, that can include your current pregnancy, that could include an early miscarriage, that can include a twin pregnancy, which would count as a one pregnancy,
Mm-hmm.
but that is your total number of pregnancies. Okay.
Mm-hmm.
Regardless of the outcome of the pregnancy, if the woman has been pregnant, that's going to count as a G.
Mm-hmm.
Your T,
Term.
your term deliveries. Yep. So that's any baby that's born after 37 weeks.
Can it be born at 37 weeks? 37 weeks?
37 weeks or after.
Yeah, and after, yeah.
Mm-hmm. So in the case of twins, right? Your mom, this is her first pregnancy. She's delivering twins. They were born living and she delivered at 37 weeks and 1 day. So her G's would be one because it was only one pregnancy.
Mm-hmm.
Her T's would be two
Mm-hmm.
because she had two living children that were born past term.
Mm-hmm. Preterm zero. A
Term would be
zero.
zero. AB would be 0. Mm-hmm.
And L2.
Correct.
So what do we do now with the stillborn?
So with a stillborn, your G is still going to be 1. Say that's her first baby.
Mm-hmm.
Her parity is going to realistically be 0.
So term 0. Stillborn preterm 1.
I would say that is a tricky one because they don't really count necessarily as an abortion because it would be the baby would be um
Yeah,
too
the
high,
abortion
too
and
high
the
in
preterm.
gestation. Um, a preterm delivery would be before 37 weeks. So if the baby was a stillborn and it was over 37 weeks, then it would technically count in your term delivery.
Greater than 37 weeks. So the preterm would be 1.
And then your living children would be 0.
And what we're going to put for the abortion? 0.
Yes.
Abortion 0. This stillborn is like a spontaneous abortion.
No, not necessarily. Because a spontaneous abortion, like that
Oh, no,
egg,
no. This stillborn was born at 37 weeks. But what if it's less than 37 weeks?
if it's earlier than, it would have to be before 20 weeks of gestation for it to be counted in that A category.
So if it was less than if it's less than 20 weeks, 1 week, 2 weeks, 3 weeks, 4 weeks, that would be miscarriage. That would be under the A.
Yes.
And preterm would be part of that too. That would be preterm too.
Preterm is going to be after 20 weeks, but
Okay, so that's a,
before 37.
okay, so that would be a 0 because if this stillborn if the stillborn is less than 20 weeks. So if the stillborn is less than 20 weeks, the G would be 1, term would be 0, but the preterm less than 20 weeks is not counted as a preterm.
No, because it would be after 30. So let me just go through each one of them and their parameters, okay? So your term deliveries, your T, is going to be any baby or any delivery after 37 weeks.
Mm-hmm.
Your preterm deliveries are going to be in that window of after 20 weeks of gestation, but before 37 weeks of gestation.
So term greater than 37 or greater, greater than or equal to 37. And the preterm you said preterm must be less than 20 weeks.
No, your preterm deliveries are after 20 weeks of gestation, so the baby's over 20, and then but earlier than 37 weeks.
Yeah, 36 and 6.
And then your abortions is going to be any delivery that happens before 20 weeks of gestation.
Less than 20 weeks.
So with a stillborn, if this mom delivers and she's 24 weeks, that would not be an abortion. That's going to be a preterm delivery.
Mm-hmm.
But if the mom has a stillborn and the stillborn is born at 40 weeks gestation, that's a term delivery. She just would not have any documented living children.
After how many weeks was that one?
After like 37 weeks. If it's a term delivery, it would be after 37 weeks. And if it's a stillborn, it would still be a delivery, but she just would not have any living children.
Yes, because it was greater than or equal to 37, but it would be not living. Not living.
Yeah.
less than 20 weeks. Mhm.
Okay, what else do we want to review?
Yeah. Since we're talking about
Yeah, I'll look at these, break them down, one at a time. Let's see. So the stillborn must be less than 20.
In what terms would we prioritize mom's vitals over baby's vitals? I kind of read where it says that when giving, I think the drug is called turboline,
Tributaline?
terbutaline. Mom's vitals will be prioritized over babies, but it's not often with me within my studies that her vitals are prioritized over the fetal heart rate. Am I correct?
Yeah, most of the time. So your fetal heart rate is very closely impacted by mom's vital signs. So usually what's happening with mom is going to be reflected in your fetal heart rate tracing and reflected in baby. Whenever you're that's like the trickiest part of labor and delivery because you technically have two patients at all times. So like yeah, most of the time your fetal heart rate is what we're going to be going off of as far as like fetal how the baby is doing during labor and how they're managing labor. Um, but yeah, there are very few times where we're like really prioritizing like what's going on with mom, but they're bothly so closely related that you have to manage both at the same time. You know what I'm saying? So like if mom's blood pressure drops like to something crazy like 60 over 30 because she's losing a lot of blood, she's had a placental abruption or a uterine rupture and she's losing a lot of blood and her blood pressure drops super low, your baby is going to have massive decelerations, right? But in that instance, what we need to solve is what's going on with mom because that's what's ultimately impacting baby. So try not to think of them as separate and which one you're prioritizing over the other because you have to think of them as one system because especially when the baby is still in utero, they're being impacted by mom's vitals.
I did some of the Saunders questions, and a lot of them on placenta abruption kind of specified that you would prepare for delivery.
Yeah. Those are patients that are being rushed back for a C-section.
Okay.
Yeah. Mm-hmm.
And they can only have those babies per C-section, correct?
Yeah.
Yeah.
Yes. So things that you would have immediate C-sections for is if like mom's uterus has ruptured or we have a cord prolapse or placental abruption or any other type or like a placenta previa. Those types of things are going to be immediately C-sections because you have to think about it like is baby going to be able to survive vaginal delivery, you know? And if like they have a placenta previa and that placenta is being delivered first, that baby's chances of survival are pretty low. So that's why we do C-sections with those patients. Same with like any type of abruption. That mom is hemorrhaging out, she's bleeding. And if she's losing too much blood, maternal blood system is not being the maternal body is going to be shunting that blood to her vital organs. And at that time, the placenta and the baby is not a priority. So that baby is not going to be getting as much blood and as much oxygen in the case of a hemorrhage. So, yeah, like with those big things, that is going to be like an immediate cesarean delivery for both maternal and fetal compromise.
So it's not like we're considering the mom, it's just a C-section to save both.
Yeah, most of the time C-sections are done for both mom and baby. It's not necessary. Sometimes you see them for fetal well-being, like if the baby's not responding well to labor, like mom's vitals are fine, but baby's heart rate keeps dropping, then we can sometimes do C-section just because of fetal indications. But there's a lot of times where it's done for both because you have to think of them as one big system, right? Because what happens to one affects the other. So we got to kind of look at it like that.
Okay. In terms with the prolapse cord, I know that the first priority is it to get is it to reposition mom to the knee to chest position, or will it be to place your get a hold of that cord on the presenting part until delivery?
You want to put on a sterile glove and you want to relieve pressure off of that cord. That is your number one priority with a prolapse. And then once you have that cord, you have relief pressure off that cord, then you can help mom be assisted into like knee to chest position or whenever their like chest is on the bed and their knees are on the bed and they're like butts up in the air. But your number one priority should be to relieve that pressure off the umbilical cord because that's what's cutting off oxygen to baby. So we want to make sure that the baby is being oxygenated. So that's our number one priority.
And is that due to low amniotic fluid?
A cord prolapse can happen for a lot of reasons.
Okay.
The times that I've seen it happen have been when mom has an excess amount of amniotic fluid and the baby's head is not very well fit onto the cervix yet. The head is not engaged. So when the baby's head is floating and then a provider goes and like ruptures their bag of water and then that cord just slips right out with all of that fluid. That is when I've only luckily had one cord prolapse, but that was when that was what happened whenever that happened. So um most of the time it's with an excess amount of amniotic fluid. And then if it's like a really small baby, if it's malpresentation, so like if the baby's breech and the mom's water breaks, they're at increased risk for a cord prolapse just because that baby might not be covering the entire cervical opening, right? So then that cord has room to kind of slip down past the baby into the vaginal canal.
So for that one, Professor, you put the gloves on and get the pressure off, physically get the pressure off the cord with your hands.
Yes.
So no C-section right away in that.
Oh, there's realistically a lot of things happen at one time. But as the bedside nurse, immediately you're putting on a sterile glove, you're relieving pressure off that cord, and you're calling for help. But then you're going to be having your hand up against that up in the vagina until you go back for the C-section. So like oftentimes the nurse who has their hand in and relieving pressure off that cord is going to be like wheeled back to the C-section suite with the patient.
With their hand still in place.
Yeah, because that's the only thing that's keeping pressure off that cord and getting oxygen to baby. So, but yeah, a cord prolapse is an immediate C-section. Because if you think about it, can the baby like that cord that's been exposed to air, like that baby is not going you're not going to be able to have a successful vaginal delivery if your hand has to be up there relieving pressure off of a cord the entire time. And also just the anatomy and phys of like that cord being exposed and already being delivered, like your oxygenation is much lower for that baby. So yeah, we're going to want to deliver that kid C-section pretty quickly.
Right away. No, putting the cord back in, settling mom down, that won't happen. You just have to have a C-section right away.
Mm-hmm.
There's a little bit of cord. Sometimes they push it back in, correct?
You're not supposed to.
Oh.
What we teach now is that you're supposed to get a sterile towel, put some warm saline, and then wrap the exposed part of the cord in that. Kind of to just mimic being in utero. But if you put a cord back up, you're exposing mom and baby to the risk of infection, right? So that's really why they teach you not to do that anymore. At least that's what like our textbook is having us is what we're teaching you guys. But yeah,
So,
usually if you're
so
having a cord
we're
prolapse,
wrapping the cord to get to the OR.
yes, yes.
But in any case, the ultimate is to head to the OR for a C-section.
Yep, with cord prolapse, that baby's gonna have to be delivered via C-section. Yep.
And how do you call for help? When you say call for help,
You hit your
down, if you're
you
close to the button, you press the button.
yeah, you press your button or you yell,
Mhm.
depending on what's easiest and what's the most available and fastest way to get someone in the room. Most of the time, if I need somebody in my room really quick, I'll hit the emergency call light. Um, that way it'll like alarm on the floor. Every hospital is a little bit different with that, but there is usually an emergency call light button at the bedside.
Mhm.
So the conditions like hypertension, and medications that are safe for mom and baby, we would prioritize hydrazine over the
Oh,
for blood pressure control.
are you asking which one we would use the most of, or what we would try to use first?
Yes, what would we try to use first? Would it be the hydrazine?
So, if you have an IV, you're always going to want to try and do something that's going to go IV because that's your quickest acting route of medication administration, right? So that's probably why they say the hydralazine versus the nifedipine because nifedipine, which is your procardia, is given oral. It's an immediate release medication, so it's supposed to be fast acting, but obviously with like any type of IV medication, that's going to be faster than any type of PO med. In my experience and what I've seen on the floor is the the one that we use the most and the one that we use first is actually your labetalol. So, with your hydralazine, that is another one that the physicians will use. So, any type of IV med is usually going to be what they want first, as long as you have an IV. The other day, I had a patient who had a really high blood pressure and she didn't have an IV in yet. And the provider just told me to just go ahead and give her the nifedipine because we just didn't have any access yet. Okay. So that is, I would say, anytime you can administer an IV medication before a PO medication when it comes to blood pressure, you should because they're faster acting.
So we should use the labetalol.
Labetalol,
Only oral, she said, typically, right?
what'd you say?
If they don't have an accessible IV, the first acting for oral would be the labetalol, correct?
I'm sorry, labetalol is IV. Your nifedipine is the only one that you'd be administering PO. So if you don't have an IV, you're going to give nifedipine. If you have an IV, you're going to most likely use labetalol or hydralazine.
So we'll go for the labetalol first. Or the hydralazine. I mean, the exam shouldn't have us picking between hydralazine and labetalol, should it?
I would,
Are they the same?
I'm not sure, but no, they're not the same. There's a little bit of difference between both of them. Let me see. There's a page that I want to tell you guys that has all of them kind of broken down. Chapter. All right. So chapter 12 in your textbook is that high risk um, care of a patient in labor. And that is where it goes into talking about preeclampsia and your hypertension. And there's a page 290, and it's table 12.5 has your hydralazine, your labetalol, and your nifedipine all written out
What,
for you.
Professor, what was that page?
290.
290.
And here, when it says under the nursing actions, under nifedipine, it says recommended for treating hypertensive emergency when IV access is not available. Okay, so that's what I would know going into your exam is that hydralazine and labetalol are given IV, and your nifedipine can be administered in an emergency if you do not have IV access.
Great, that makes sense. Thank you so much.
You're welcome.
So, I was jotting down something. Labetalol in an emergency with IV. No IV, we use the nifedipine. No
Yep.
IV access. And what
Yep.
do we do with hydralazine?
Hydralazine and labetalol could be used
Together.
if you have an IV, and it's usually
Okay, got it.
provider's choice, like whatever your doc tells you to use.
Mhm. Got it. But they say labetalol is better for the pregnant mom. It has less any kind of effects.
Yeah. There's less effects for both.
The hydralazine too?
Hydralazine has a little bit more side effects
Yeah, I give
for
lupus.
babies and moms, but the labetalol has less, which I think is why providers use it more
Yeah,
often.
hydralazine gives lupus. But when you get off of it, the lupus will be gone.
Yeah, I'm not sure. I did not
Yeah.
know that.
That's an aside. It might not be. It does. Hydralazine does.
Yeah.
Mm.
So we have about 5 minutes left in the review. Does anybody have some like last minute stuff that they want to ask?
Mm. Anything on diabetes that is gonna be tricky?
I would just know like how diabetes can affect like a pregnancy, how you're going to change the insulin dosage based on the trimesters that the mom is in.
Yes, that one. How less insulin in the first trimester, but more insulin in the second and third trimester.
Yeah, yes.
Are they gonna ask for the actual amount we're gonna give? I mean,
I am not sure. Yeah,
get-
I'm not sure specifically what the questions are going to say.
I know,
But I would know. I would definitely know about your gestational diabetes. That's going to be something that is important moving forward in the class. Definitely know about your hypertension disorders. Those are the two big ones that we're seeing with pregnancies, right? For your cardiovascular disorders, know the difference between like open glottis pushing versus closed glottis pushing, and if we should be using that with moms.
Anything tricky about that?
Sorry, what was that?
And anything specific about the open and closed glottis?
So if your mom has underlying cardiovascular issues, we don't want her to do closed glottis pushing because she might vagal down and we don't want her to pass out.
Mm.
So teaching them like an open glottis pushing technique, which I have a video on one of my PowerPoints, but I'm not going to be able to find it right now. If you just like Google open versus closed glottis pushing, it'll show you the difference between the two. But yeah, we want them to push open glottis because that's not putting as much pressure on their vagal nerve and it's going to help them with circulation and preventing them from passing out.
Mhm. Okay, thank you.
Okay. But I'm going to be posting this video and all the to all of your professors. So your guys' professors should get this recording and they'll post it with their they'll update that announcement that Professor McBride sent to all of the classes. And so all of the recordings will be available for you for the review sessions too. Okay.
Mhm. Okay, thank you.
Yeah, thank you guys
So it's
for
gonna be posted in the email or in the announcements?
I would look for it in your announcements. I'm not sure how each individual professor posts these. I usually just post it directly to my Canvas and send an email telling my students it's been updated.
Okay, can you send it to me, because I'm not in your class?
Well, your professor, Professor Roberts, she should be updating her announcement in Canvas and posting my review as well. But if she does not, then you can email me and I'll send it to you.
How do I get your email? I get it from,
Let me see. I can give it to you.
put it in the chat.
Yeah. Okay, that's me. So if you need to email or you need the recording, just let me know. But your professor should post it into your Canvas for you.
Got it.
All right. Well, I hope you guys have a great day. Thanks for coming to the review. Good luck studying.
Okay, thank you so much. Thank you for doing that GT with me.
You're welcome. It can be a little confusing.
Right, especially if you have to do it in a rush.
Yeah, it can be a little confusing, that's for sure. So no worries at all.
Okay,
All right. I'll see
thank
you
you so
guys
much.
later.
See you later.